Hello, everyone. My name is Clemens Becker. I have the honor and the pleasure to lead the clinical validation study of Mobilized, and it has been quite a journey. About 3 years are behind us and 2 years are ahead of us. So today we have prepared two parts to give you the deeper insight into this very exciting project. So in the first part, you will hear a lot of background information from Professor Rochester, who's leading the consortium. Then I will present the planning of the study, how we prepared the study, how we're running the study. And then as the third part of the first half, Dr. Janssen will present the study protocol. Then after a session for questions and answers that you can put in the chat, then we have the second part where we will give you the background information of the very different cohorts that we have included in Mobilized, which will be a presentation on Parkinson's, on COPD, on multiple sclerosis and hip fracture. And after that, we will have a second part on questions of answers. So thanks for joining us for this very exciting journey. And now it's a pleasure to hand over to you, Lynn Rochester.
Thank you. So good afternoon, everyone. It's indeed a pleasure to be here today to introduce the overall Mobilized Consortium to you and to set the stage for the clinical validation study that you're going to hear about for the rest of the afternoon. My name's Lynn Rochester. I'm the coordinator of Mobilized. I'm based at Newcastle University in the UK, and I have the pleasure of co-leading Mobilized with Dr. Ronan Rubinoff from Novartis. Here is my disclaimer and also acknowledgement to the EU IMI initiative for funding the Mobilized Consortium. So this is, you'll see on this slide, the overall objective of the Mobilized Consortium. We are aiming to deliver a valid solution for real-world digital mobility assessment. We're doing this across multiple conditions that you can see represented on the in the image on the right-hand side. All of these conditions affect mobility. And in doing so, we hope to bring digital mobility outcomes from concept to widespread adoption. The approach that we're taking to real-world assessment is to ask our participants to wear a single body-worn device. They wear it continuously for 7 days, and we use this collection period to collect our real-world digital mobility outcome data. And the approach, we hope, will transform health through real-world digital mobility assessment. So this, there's an overview of the work of the consortium in the publication shown on this slide. But in essence, Mobilized, in order to achieve its objective, which is very ambitious, has to address the 3 grand challenges that you can see on this slide. We have to firstly show that we are able to accurately measure real-world digital mobility outcomes in the real world so that we are technically valid. We then need to be able to show that our outcomes are clinically valid. They tell us something that is important about each condition of interest, and also they are clinically meaningful. And then finally, we need to take the package of evidence that we've accumulated and present this to the regulators so that hopefully our approaches will be adopted as a new method for use in regulatory trials, drug trials, but also in healthcare in general. So an objective like this is really ambitious, and this requires an equally ambitious strategic, multidisciplinary, multi-stakeholder approach. And let me introduce you to the Mobilized Consortium. Mobilized is a partnership of 34 institutions from academia and industry. As I said earlier, we're funded through the IMI initiative, the EU IMI initiative. You can see some key facts on this slide together with our partner logos. We commenced our work on the 1st of April 2019, and we're funded for a 5-year period. Importantly, this consortium requires significant partnership working. So it's not only a partnership between academia and industry, we have significant partnership working with patients, with regulators, and also with healthcare professionals and healthcare systems. For example, our work with patients and the public is through our Patient and Public Advisory Group, and I encourage you to listen to the webinar on June the 1st that was just introduced by Mara, which is describing how we are working with our patients to ensure that everything we develop within Mobilized is fit for purpose. So why are we interested in mobility? Why is this our important concept of interest? You can see a definition of mobility on how we are defining this on this slide. From the public perspective, it's fairly obvious mobility is important. Mobility loss is common, it's increasing, and recent data from the EU highlight that 1/3 of adults over the age of 75 experience severe difficulties with walking. And of course, that's only increased in those living with chronic long-term health conditions. Mobility loss profoundly affects quality of life, and it's an important personal aspect of health, as you can see in the comments on this slide. From a measurement perspective, mobility also is important. Research shows that changes in gait or the way we walk, such as a slow walking speed or less walking activity, not only indicate that our mobility is getting worse, but they also reflect changes in the disease process itself. For example, they can indicate an increased risk of disease progression or adverse health events such as falls, institutionalization, or exacerbation of respiratory conditions. And for these reasons, discrete mobility outcomes are considered to provide a sixth vital sign of health. So mobility is therefore an important target for intervention in multiple conditions and also an important feature to measure and monitor. And the measuring and monitoring is what Mobilized is all about. So what's the current state of the art of mobility assessment? Well, I think it's fair to say that the current tools that we have got some recognized limitations. For example, the way they're delivered means that they lack precision and sensitivity for the task. The tests often don't measure what patients care about and therefore lack relevance. This is incredibly important for regulators who want to see that any treatments are really changing aspects of health that are important to patients. Tests also often require a face-to-face visit, and this reduces inclusivity. And again, this is a really important feature of trial design, because that means if you don't have the right people in your study, if it's not diverse and inclusive, then the results lack generalizability and trust. So we urgently need the next generation of precise digital tools that can measure and monitor mobility in the wild with an approach that can be used in multiple conditions in order to streamline mobility assessment and establish mobility as a core concept of interest in multiple conditions. So what do we know to date? Well, evidence from Polhemus and colleagues from the consortium demonstrated in this seminal scoping review demonstrated that there was clinical validity of digital outcome measures in a review of over 800 studies. And they also scoped the literature across the range of conditions relevant to Mobilized. So their review supported our harmonized approach to mobility assessment. However, what they found was that there was a clear evidence gap for clinical validity in real world scenarios, and that's a gap that Mobilized will directly address. Jaeger and colleagues carried out another seminal review, and in this review they explored the use of mobility as a decisive outcome for the marketing authorization of drugs across a range of health conditions that affect mobility. They did this through a review of European public assessment records, and what they found was, in general, that there was a fragmented approach to mobility assessment that was inconsistent, uncommon, and importantly, there was no evidence of digital mobility endpoints being used. So despite the importance of mobility, despite emerging evidence for digital mobility outcomes, it's not measured. And possibly this is because of some of the limitations I've just highlighted. So we aim in Mobilized to describe mobility performance. You can see the definition here, what people actually do, using a range of validated digital mobility outcomes derived from our device and algorithms that run on the device. Our primary outcome measure is walking speed, but we have a range of secondary outcome measures. You can see some examples provided here. And in doing so, taking this approach, we aim to measure what matters to patients, when and where it matters in the real world, delivering relevant, inclusive and resilient tools to drive efficiencies in clinical trial design and delivery. So I just want to go back to our 3 grand challenges just to set the scene. So to be able to clinically validate digital mobility outcomes, our second challenge, we first needed to identify if we can accurately measure them in all of our cohorts of interest in the real world. And that was the subject of our first webinar series. I encourage you to listen to that. If you go to the Mobilise website, you'll be able to find the videos on our YouTube channel. And you'll be able to hear in more detail about the work that was carried out. But just to give you an overall overview, the approach to technical validation is described in detail in this protocol paper by Matzer and colleagues. Technical validation was established independently in these 3 core domains that you can see here. The performance of the device and accuracy was separated from the performance of the algorithms, the validity and reliability of the algorithms. That was also evaluated in the laboratory and in the real world in all of our cohorts. And then importantly, we also carried out a piece of work to ensure that our protocols and measurement approaches were accessible to patients, and also assessors so that they would be used. And by adopting this approach, we aim to comprehensively provide the evidence that yielded technically valid digital mobility outcomes. You'll notice here that I'm indicating that our work is agnostic, device agnostic. This is really important for widespread adoption, allowing algorithms to be used on a range of devices with the appropriate technical and user requirements. So I'm going to summarize 3 years of significant effort in 2 very quick slides of the findings from the technical validation study, the TVS. What we can say, just to summarize, is that the results are generally very good for the majority of our digital mobility outcomes of interest, our primary outcome measure, walking speed, and many of our secondary outcome measures. But it's fair to say from our results that error does increase where gait is very severely impaired, such as in people who are recovering from a hip fracture, who walk very, very slowly. And this fact is further increased by walking aids, the use of walking aids such as rollators. So it's something that we need to be aware of. We also found that very short walking bouts, such as those below 10 seconds, increase error, and removing those improves our results. And these are considerations for interpretation and further analysis for the clinical validation study. But in summary, we can say that the digital mobility outcomes that you can see in the column on the left-hand side achieved the acceptable level of technical validity, i.e. they met or exceeded the criteria for digital mobility outcome validation recommendation. And they will be the focus for the clinical validation study, which is being taken forward and you're going to hear about now. Importantly, these are initial findings, and I'm showing you findings from outcomes where very short walking bouts have been removed to improve performance. So that very nicely leads me on to the second grand challenge, which is the subject of the rest of the webinar today. Are our clinical mobility outcomes that we know we can measure accurately, clinically valid and meaningful? And at this point, I'm going to hand back to Professor Becker, who I am delighted to say is leading our clinical validation study and will provide you with more detail. Thank you.
If you have questions, please put them in the chat. We'll take the questions and your comments after the first 3 presentations. So I will take over, let's say, how based on these findings from the technical validation study, we planned the clinical validation study. And as Professor Rochester has said, our aims is not only to influence trial design and future regulatory decisions, but also, let's say, to have a somewhat normative approach towards clinical endorsement and uptake in these quite different areas. And it was definitely a very interesting learning exercise because very often we work in pillars and we can learn a lot from, let's say, the different disciplines that we have enclosed in our planning. So the background is, as we have heard, that we not only have a global pandemic in terms of deconditioning, but we have the aging processes across not only Europe, and we have a lot of chronic diseases that are very closely related to mobility, and we need to study not only the course of the disease, but also the interventions that we can offer. They might be pharmacological interventions or non-pharmacological interventions. We know quite a bit, let's say, and have learned a lot about, let's say, different parameters that we can use. Of course, we are aware that a lot of these conditions might lead to disability, might lead to hospitalization, and also physical activity and inactivity are associated with survival. And we're interested in further establishing the roles, not only in research, but also in clinical practice, and realize that the indications can be quite different, for instance, in the assessment process, in prediction, modeling, and stratification, for instance, for treating someone or not treating someone, monitoring, but also, of course, for the evaluation, let's say, of these very highly prevalent conditions that were chosen for this call of the IMI office. And then, of course, at the end of the day, we want to demonstrate the added value and the unique features of digital mobility assessments and outcomes. I think one pivotal study that was published, including some of the co-workers of Mobilized, was published in Lancet Public Health a couple of weeks ago. And what it shows is that we need digital assessments as part of the clinical work. For instance, if we want to assess the volume of step counts, physical activity, mobility disability, there's no way that we can assess these features by only asking patients or having supervised assessments. This is a multi-center study, including more than 40,000 subjects with global sampling, and I think it will be, or it will demonstrate to be, a pivotal study to underline the needs for digital mobility assessments. As briefly has been mentioned by Lynn Rochester, within this consortium, we have conducted, I think, this landmark study that was led by Ashley Primus from Zurich. And on the left-hand side, you can see what we consider are the parts of the taxonomy that we should consider when we discuss mobility, which are the features of pace, of rhythm, of the different phases of walking, to look at the base of support, to look at the variability of different mobility features, to look at asymmetry and volume. And as you can see, a lot of these features have been used quite differently across different conditions. We'll come back to that if we present the cohorts, but we need to understand what these features mean in terms of, let's say, prediction, monitoring, and so far as the items that I've mentioned. And this taxonomy now has been published also by our co-workers Felix Kluge last year, and it presents, in a sense, the table, let's say, how we can, or the matrix, how we can look at mobility in a very precise manner. So what we have done, and a lot of people thought that during the pandemic, this was not feasible, but we have shown that it is feasible, that we wanted to recruit in each of these cohorts 600 patients, and the cohorts are COPD, are hip fracture recovery groups, multiple sclerosis, and Parkinson's. For 3 of the cohorts, the recruitment process is almost accomplished. There are a few persons missing for the MS cohort. For the recovery cohort of hip fracture, we have said we must extend the window, but despite all the problems that we encountered all across Europe, we were capable of recruitment. And this, for some, at least to some degree, shows that patients and also participating clinics and healthcare workers are super motivated to be engaged in this work. This is a brief modeling of how we set up the study. So these patients are being assessed every 6 months. We have an assessment of 7 days where we use the digital mobility sensor platform that you will hear about in a minute. And then, of course, this comes along with data cleaning and data management. And then, of course, we have a pre-planned statistical analysis plan that we are following. And we will start with cross-sectional analysis. I will show the timeline in a little while. And then, of course, we will also look at the perspective analysis. The overall aim, following the principles of open source and open science, is to build this platform, which at the end of the project would also make publicly accessible to others. We have a lot of primary and secondary endpoints that we are interested. And one of the relatively unique features is that we're not only looking at the different disease entities that we'll hear about in a little while, but we are also looking at changes across the different cohorts, for instance, in terms of function and the development of disability. In order to do that, we're using the Late Life Functional Disability Index, and we're using different digital mobility outcomes in terms of monitoring and prediction. In terms of event prediction, we have chosen, let's say, the typical features of each condition, which is for COPD, the number of exacerbations, including hospital admissions caused by exacerbations. For multiple sclerosis and Parkinson's, we're looking at the event prediction of falls and fallers. And for the hip fracture population, we're looking at care home admission and mortality, which are relatively frequent outcomes in this very old cohort. What we will be doing is that we will be using the different DMOs that have been mentioned and to look for their potential in terms of prediction and monitoring. And this is one example of the development of the sample size calculation. And it shows that given the numbers that you have seen and that I've reported, we will be capable to look at different DMOs for, let's say, prediction and monitoring modeling, and to look at also meaningful differences across the different cohorts. In order to do this, of course, it's super relevant, let's say, to build a solid platform. This was done, and this work was led by Brian Coldfield and his team from Dublin. But we also have the industrial partners of Clarion and Icon on board that helped a lot with it. And the other partner, which is very relevant, is the team from Newcastle, which is also responsible for building the database and the data warehouse that we will be using. So this is a lot of team effort. Overall, we have more than 100 people that are involved in this process. So as you've seen, the technical validation study has come up with very powerful algorithmic processes. We have established how to run these validation processes, for instance, for future sensor platforms, how to replicate that. For the technical validation study, the work on the baseline data has now started. We're developing monitoring matrices. We're developing prediction models built on these, let's say, features. And of course, this process takes time. The data need to be cleaned, need to be analyzed. We have to publish and then share the data. And of course, this is a long road. So if you're interested, of course, it makes a lot of sense to start this team building process, also beyond the process. And let's say some of the features that we're now heavily involved in is the consensus building process of what are the most successful DMO candidates and combinations, on data aggregation, also on features from a clinical perspective, on minimum measurement duration, the requirements of the sensor platforms, sensor placement, and so forth. So to give you some indication on the timelines where the first results will come out of the clinical validation study, we expect that in the first half of 2023, quite a number of results will be available on test-retest reliability criterion, validity. The work then is starting on construct validity, on prediction, and also on ability to change. Of course, for this feature, we will require some time for this observational study. So most of these results will come out in 24 onwards. More or less to finish up, what we have learned also with our discussions with EMA and FDA, that a lot of these regulatory bodies are very interested in the development of digital mobility assessments and outcomes, but it takes quite a bit of time. This discourse will be carried on, but something which was not a surprise to us, but it's super relevant also to look for data from randomized controlled trials, either pharmaceutical trials or the non-pharmaceutical trials, because the regulator are, of course, in their world living, mostly interested in outcomes that are, let's say, shown by intervention trials, classically randomized trials. So a year ago, a lot of people thought that this is a mission impossible. We can now say that the recruitment process has been quite successful according to our planning. And I will now hand over to the next speaker, who will show us how we've planned the preparation of the clinical validation study, how we trained our assessment teams, how we recruited for the clinical validation study, and how we have been running the clinical validation study. So the next speaker is Carl Philipp Janssen, who's a postdoc from Stuttgart. Carl Philipp, please take over.
Thank you, Clemens. Yes, so yeah, there's many how-tos that you mentioned, and I'm trying to cover as much of this as I can. To already go into the details of what we're doing, I want to quickly go back to the main aims of Mobilise, and these are huge in terms of their meaning and implications, but of course not easy to well achieve. So we want to verify whether DMOs can be used as disease-specific monitoring biomarkers to account for mobility performance, which is an important word here, in assessing the efficacy of new treatments for patients. And there are 4 cohorts in which we are doing this, and you will learn more about those cohorts later today. We want to verify whether DMOs can be used as disease-independent monitoring biomarkers to account for mobility performance, and also whether they can be used as surrogate endpoints to replace currently used and accepted clinical endpoints. And this would require that they are more difficult or expensive or time-consuming than the DMOs, if that should make sense. And then at last point, for qualifying DMOs as a monitoring biomarker of disease status. So it's quite a bit of work to achieve that. And of course, there are many question marks behind it. But yeah, how are we trying to do this? And of course, I cannot cover all of the work that has been done and all of the issues that are related to this, but I'm trying to get into it. But before I do that, I've mentioned the word or the term mobility performance, and what actually is mobility performance. So the WHO in 2001 introduced the ICF, and the ICF has several components, of which activities is one. And this component can be separated into 2 constructs, capacity and performance, which are, well, 2 constructs within the ICF. And performance can, again, be distributed to perceived performance and actual performance. Now, it's important to understand the difference between capacity and performance. And to do that, I want to quickly explain what the meaning is. So the capacity is what someone actually can do. So it's what you grasp as part of lab testing, and it reflects environmentally adjusted ability of the person. On the other hand, the question what someone actually does do in their real life is a different one. And to assess that, you need to measure mobility in the place where it occurs, so in the environment of the individual. Now, to do that, as part of our study protocol, we have two ways of looking into this, and I want to dig a little bit deeper here later. We have 5 visits as part of the clinical validation study. So we start with baseline, of course, and every 6 months, persons or patients come back to us, and the assessment battery differs depending on the time frame. And of course, the baseline is a very big one, and also the follow-up at T5 after 24 months is covering a lot of assessments. Now, the green, highlighted in green here, you see the digital mobility assessment, which is done over 7 days, continuous measurement using sensors. And what we also do at every time point is that we measure physical, or we conduct physical measures, physical assessments, which should complement and give us information on the capacity. So it's not all of the story. So we have digital mobility outcomes, we have clinical outcome assessments, we have patient-reported outcome measures, such as the LLFTI, which I will show you in a few minutes. We have clinician-reported outcomes, observer-reported outcomes, and we also have, of course, the performance outcome measures, such as the capacity tests. So it's a huge assessment battery covering many different assessments, and we use a lot of devices for this. And it's maybe a very good opportunity to also thank the patients for their patience in doing all these assessments with us, because they have to really participate in a lot of questionnaires and so forth. Now, who are they? The exclusion criteria are much longer than you can see, than what you can see here. Of course, some of those criteria are obsolete, so I've omitted these. But we have several that are maybe important to mention. So we're looking into adults aged 18 years and older, but in hip fracture, they have to be 45 years and older. They need to be able to walk at least 4 meters with or without their walking aids. Of course, they need to be able to consent and comply with study procedures, which has some implications for cognitive impairment. And they should have no occurrence of a rather long list of certain diseases, which you can see here on the right-hand side. I'm not going into the details here, and we also have cohort-specific inclusion criteria that go beyond what you see here. Now, the primary outcome, Ms Becker has mentioned it, is the late life function and disability instrument. And unlike the Dmos and the capacity assessments, this is something that is patient-reported information, and we perceive that this is a very important part of the story. And it covers 2 factors. It's the function and the disability. And for function, it is asked how much difficulty someone has in doing a particular activity. First, without the help of someone else or the use of assistive devices, but in those persons who actually have assistive devices, it is also asked with devices at a later stage. And they can answer in either say they have no problems, a little, or difficulty, a little difficulty, some, quite a lot, or even they cannot do the certain activity. Opposed to the function, we have the disability part, and it is asked to what extent the person feels limited in doing a particular task. So they can either feel not at all limited, a little, somewhat, a lot, or even completely limited in doing a particular task. And it's a rather long list of activities and tasks that are asked, and it's a very elaborate questionnaire. So we feel that we have a lot of information about the perceived function and disability of the patients in our study. Now, in addition to that, we have the real-world mobility performance, which is assessed using devices, sensors, and we have 2 different sensors in our study, the McRoberts Move Monitor and the Exivity AX6. So the McRoberts device is worn on a belt around the hip, and the Exivity is placed using adhesives right on the same spot where you can see the McRoberts sensor. And if you're interested in the outcomes, and Lynn Rochester has touched it already, you can go on the Mobilized website and check for the TVS webinar, which covers a lot of ground on that part. Now, in addition to the performance, real-world mobility performance, we look into in-lab capacity. And for that, we're using a sensor as well. We're doing the short physical performance battery, the timed up and go test, the 6-minute walk test, the hand grip strength test, and the use of mobility aids. And the first 3 mentioned here are actually instrumented using the McRoberts Move test sensor. And just to quickly explain why we're doing this, so you can see here, for example, an output which is generated following a 6-minute walk. And you can see here that you get information about the walking trajectory over those 6 minutes and the turning direction, walking velocity, step frequency, and also step length across those 6 minutes. And for example, the 5-time chair rise, which is part of the short physical performance battery, you get a visual interpretation of the sit to stand and stand to sit movements, but also, of course, you get numbers, times, angular velocity, and so forth. And as my last example, for the timed up and go test, which means sitting on a chair, standing up, walking 3 meters, turning around, walking back and sitting down again, you have certain segments which you can see here, the stand to sit, sit to stand, and also the first and the second walk and the first and the second turn. So the second one is before sitting down, and you get information about the duration of this, also other information such as angular velocity and number of steps for turning and so forth. So to summarize this quickly, you have additional information for which you can use, and you get segmentation of test movements. You have information on gait and turning parameters. Of course, from a clinical perspective or a clinician perspective, visual interpretation can be really useful, and you can compare the sit to stand, stand to sit movements, and so forth. So there's a lot of information we get here, and we feel that overall, this gives us a very, I would like to say, holistic view of mobility of the patients we have in our study. Of course, there's a lot more assessments that we're using, and the webinar does not give us enough room to actually cover that ground as well. So this is my part, and we can now start with the question and answer session, I would say. Thank you.
Thank you, Carly. Currently, I see no questions in the chat. I think if that is not the case, maybe very briefly to mention that we've also, let's say, recorded all the training procedure for the assessment teams using a webinar approach. So if someone is interested, let's say, to be in touch how to train assessors using a webinar platform, that's been a story of success. So please be in touch with us. So I think then we can save a little bit of time, and then we can hand over. So the first presentation from the cohort perspective will come from Parkinson's. So I will hand over to Professor Walter Metzler from Kiel.
Thank you very much for giving me the opportunity to present here in a few minutes the basic idea of the Parkinson's disease cohort as well as the structure. And what you see here is the overview of the sites where they are located across Europe, including here Israel. This is Newcastle and Leuven and Kiel and Erlangen and Tel Aviv. And the main PI and contributors are Alison, Heiko, Alice, Nia, Jeffrey, and myself. So what is Parkinson's disease? Parkinson's disease is a chronic progressive disease and starts between in the 60s and 70s mainly, can also start in the 40s and 50s. And the interesting aspect is that it has a long prodromal phase, up to 20 years. There were first non-motor symptoms occur, also motor symptoms 2 to 3 years before we can diagnose Parkinson's on a clinical basis. And then what we measure within Mobilise-D is the phase from early Parkinson's disease to advanced Parkinson's, not to very advanced, but advanced Parkinson's, where you see that a lot of symptoms occur. Many people say that Parkinson's can suffer from up to 150 symptoms. So this disease consists of motor symptoms and non-motor symptoms and of complications, and the focus of Mobilise-D is of course on motor deficits. And what I want to show you here is that this is a very serious part of the disease. For example, bradykinesia, which is the main cardinal symptom of Parkinson's disease, also postural instability and rigidity, they increase over time and lead to reduced mobility. And the non-motor symptoms, but also episodic symptoms such as freezing, dystonia, and dyskinesia, also loss of muscle power and muscle mass, lead to aggravation of the immobility, and also cognitive and behavioral symptoms. This is reflected by not only a reduction of the overall mobility, but also on the micro level of mobility, as we know, for example, for reduced step lengths and increased step variability. The Hoehn-Yahr scale is a very nice scale and a very simple scale that can give us an idea how this disease has an influence on the daily activity and the quality of life of the participant, of the person affected. In stage 1, the one side is affected. Stage 2, 2 sides are affected. Then the postural stability is affected in stage 3, and stage 4 means that you need a walking aid, and 5 means that you are no longer able to move. Then how do we test currently the disease? Mainly in clinical trials. That is, if I do it as a clinician, then I use mainly the MDS-UPDRS-3, which tests mainly motor symptoms, and you have an idea of these symptoms that are tested in front of the patient. And if you have a closer look, then you see that most of the items have somehow to do with mobility, which also shows how important the mobility aspect in Parkinson's disease is also for the clinician. We have also instruments for patients to rate the severity of their disease, and most validated and established one is the MDS-UPDRS-2. And I show you with this example here on walking how this basically works. This is always items 0 to 4, where you start with normal, then mild, moderate, severely affected, and then 4 means that you can barely, you're not able to do anything. Now, moving one step further in the direction where Mobilized is doing this really groundbreaking work. This is from a systematic review from Ashley and colleagues published a few months ago, where she collected all the information currently available, how these parts of gait are associated with different aspects of a disease, here shown associated with diagnosis, here patients versus healthy controls. And you see here that pace, the greener, the more significant and the more associated, that pace and also the variability aspects of gait are very strongly associated with the accuracy of diagnosing Parkinson against controls. What is also interesting is that there is these gait features obviously have something to do with the course of the disease, with the progress of the disease. As you see again here, mainly also pace is reduced, also rhythm of course, but again some information also can come from variability changes during the course of the disease. I think this is also a very important aspect here, that we have already some data on response to treatment in Parkinson's disease in association with these gait variables. And you can see again that pace and variability parameters seem to play a very important role. So why do we need such unsupervised DMOs in Parkinson's disease? This is shown by a review on the Viewpoint published recently that shows that if you have different parameters of gait and you measure it in the clinic and in the unsupervised environment, and you compare then this specific parameter, then you see that almost none of them behave very similarly if you collect information in the clinic and at home. And you see, even if you collect one and compare it then from between clinic and home environment, you see that there are deviations up to 150 and more % with the same parameter. So it's really important that we collect such information in the home environment where it's really happening, where it's really important, where life matters. Also in Parkinson's disease. I conclude with the following statements. Mobility deficits are important in Parkinson's disease. They are associated with the occurrence of the disease and the progress of the disease. It is also associated with number of falls. And gait is a relevant part of mobility, and this is centrally affected in Parkinson's disease. And as we have learned, Dmos can measure these structure aspects of gait and also quantity of gait, and this is associated with the occurrence, severity, and response to treatment in Parkinson's disease. Most promising parameters seem to be, as we currently understand the situation, gait speed and time variability, but there is a lot of research to do and to see whether other parameters, including, for example, frequency parameters, may give us additional information. And again, Mobilized covers a very important aspect also in Parkinson's disease, as we know also in Parkinson's disease that there are substantial differences between the parameters if we collect them in a supervised or unsupervised assessment. Thank you very much.
So the next speaker is Thierry Troosters, Professor Troosters from Leuven. Please take over.
Yeah, thanks very much, Clemens, for the invitation. It's a pleasure to present the branch of COPD within the Mobilized Consortium, and I'm doing that, of course, on behalf of a number of people across Europe. You can see them here. They are the team leaders of different teams that are taking care of our COPD patients across Europe. In Northumbria, now Yanis Fogiatsis in London, Nick Hopkinson. In Athens, we have Nick, a partner, Anja in Zurich, Judith in Barcelona, Henrik in Großhansdorf, and then in Leuven, Helene Meyer and myself to sort of take care of the COPD cohort. COPD is a very prevalent disease, and that's perhaps why we have actually completed our recruitment and finished with our 600 patients at baseline, and are now trying to follow these patients up for 2 years to see how their mobility is affected by their disease in the next 2 years to come. And that's an exciting journey. We're just in the beginning, but we're very motivated to continue. COPD is a disease that is characterized by a progressive reduction in lung function, and with this also ventilatory capacity of patients. So our patients have difficulties breathing and hence also accomplish their usual activities in daily life. And when Netter was drawing his COPD patients, the emphysematous patient and the patient with chronic bronchitis, he depicted these patients probably deliberately in the 60s sitting in a chair, because COPD is indeed a disease that clearly affects the mobility and the physical activity in our patients. This lung function problem also leads to altered breathing and has an impact on lung mechanics, and that results in symptoms of dyspnea and then causes inactivity, which then subsequently leads to a number of non-respiratory consequences, muscle weakness to name one that is very prevalent in patients with COPD, and it also causes a lot of comorbidities. So physical inactivity is really one of the key points in the development of the disease burden for patients with COPD. The disease is not a constantly evolving process, but it's punctuated by exacerbations, and these exacerbations, aggravations of the lung function deterioration in patients, so these exacerbations are linked themselves to more inactivity and mobility restriction. Many of the patients that suffer from an exacerbation, an acute exacerbation, are housebound and are really even more limited in their mobility. And so this then leads to further systemic consequences. And one of the key things that we want to prevent in patients with COPD is indeed these exacerbations. So no surprise that this will be our primary endpoint in patients. We and others have shown that physical activity progresses through the disease, and if you go from mild to moderate to severe and very severe disease, physical activity levels gradually decline over time, and this is now known for many years. And here is research from our group here in Leuven, but also Henrik Watz's group in Groß-Hansdorf, one of the partners in the Mobilized Consortium for COPD. And what you can see already here, and perhaps more clearly here on the right-hand side of the graph, is that patients early on in their disease process already start losing physical activity. They drop their mobility, and this is basically to stay under the radar of diagnosis, because if you don't do anything, you will not suffer from the symptoms of chronic obstructive pulmonary disease. And so patients try to avoid symptoms by becoming less active and dropping mobility levels. And so that's why these patients are then trapped in a vicious circle of inactivity, the development of comorbid conditions, and that makes the disease actually worse than it actually should be for the lung function deterioration. And this has now been picked up in international guidelines. And if you look at how to diagnose and then treat patients with chronic obstructive pulmonary disease, you can see an iterative process of initial management, a reviewing of that management, adjustment, and again, reviewing of that management. But you see that physical activity sits really in the core of how to manage these patients. This is what doctors will look for. And unfortunately, we don't have instruments to actually look at mobility in daily life of our patients with COPD. And we hope that Mobilized will provide us with some tools to get better insight, or to get even better insight in mobility impairments in our patients. So what do we use then? Like Walter already presented for Parkinson's, we try to use questionnaires, and we have functional assessments that we do in the lab, and the incremental shuttle walking test or the 6-minute walking test are very frequently used, but they don't tell you how the patient is actually doing in his or her daily life situation. So increasingly, we've started using physical activity monitoring, typically geared at looking at the volume of physical activity. And Helene de Meijer recently published, together with a large international consortium, how to do that in research activities. But still, this is just scratching the surface of this field, and we hope again that with the Mobilise-D project, we will get even better insight in this. When we ask our patients what their problems are, and this was done by Fabienne Dobbels as part of the Proactive IMI project, our patients complain about having reductions in the experienced amount of physical activity, and then symptoms that they perceive and adaptations that they have to make to their daily lives. And if you look at what exactly these problems are, then you see that we're now coming closer to the concept of mobility that was already discussed by Clemens earlier on. Patients not only complain about symptoms, but they also say that they have to take breaks. So the bouts of activity become shorter. They have to adapt their pace and walk slower. And that is exactly what we want to pick up in the Mobilise-D project in these patients, to see how that is important in the development of the disease process in our patients. And looking at experienced amount and experienced difficulties and adaptations that patients have to make, we know that we have interventions that are geared towards improving amount and difficulty. For example, if you want to make patients do more, then you have to coach them towards a more active lifestyle. If you want to reduce their difficulties, then you have to give them a bronchodilator. And exacerbations are actually impacted on or impact on the amount. Patients will do less, and they will experience more problems. So that's why we chose exacerbations as one of the primary endpoints in the COPD cohort for Mobilise-D. There is a little bit of a historic difference, I would say, in how we look at mobility if you compare, for example, the patients that Walter discussed earlier on Parkinson's and patients with COPD. In that in Parkinson's disease, you can see that the gravity of the research is more on gait speed and how patients exactly walk, whereas in patients in COPD cohorts, we typically look more at physical activity parameters, the volume of physical activity, the walking time that is conducted in these patients. And very few studies have actually looked into how patients exactly walk. And again, we hope to increase our knowledge on that with the Mobilise-D consortium. We also know that in terms of volume of physical activity, bronchodilator treatment, rehabilitation has some impact, but a limited impact. And we believe that perhaps these interventions may have a bigger impact when we look at, for example, walking speed. And that is because if you look at a conceptual framework around how we can look at outcome measures in patients with COPD. You have, of course, organ physiology, and that is where most of our interventions have an impact. Bronchodilators, for example, will have an impact on lung function. Exercise training will have an impact on muscle function. Exercise tolerance is more of an integrated outcome, and physical activity is then even more down the line, if you want, and more factors will start to impact on physical activity. Things like confidence, the physical environment around patients, the habits of patients, social environment around patients has an impact on physical activity. And that's why a bronchodilator does not necessarily have an impact on physical activity in itself. But we hope that with the DMOs, we come closer to exercise tolerance, what patients can do, the length of their bouts, for example, the walking speed that patients have. And we believe that since this is a little bit closer to where our interventions have an impact on, the effects of interventions will be more easy to pick up. And so we look forward to seeing these DMOs validated in patients with COPD. And obviously, we will also use the Mobilized-D consortium to get even further insight in more physical activity related DMOs. So in summary, physical activity or the loss in physical activity characterizes the disease progress in patients with COPD, and patients drop their mobility even before they are diagnosed, actually to prevent them from being diagnosed. Exacerbations punctuate the disease progression, and they are important endpoints also in clinical trials. Patients with poor mobility typically experience more exacerbations. I haven't sort of given you all the evidence for that, but we know that patients that have lower physical activity levels will have more exacerbations, and exacerbations will then reduce physical activity levels in patients with COPD. The DMOs that we will be looking at in Mobilized-D can measure the impact of COPD, and treatment interventions can have an impact on these DMOs and will then reflect true benefits for patients with COPD. The deterioration in DMOs is likely to predict adverse outcomes in COPD, and we feel that if we can properly measure real-life walking speed or other digital mobility outcomes in patients with COPD, that we can really get a hand on things that are really important for our patients and are accessible to clinicians. So we believe that this will allow us to look better at the impact of pharmacological and non-pharmacological interventions in patients with COPD. Thank you.
Great, Thierry. Thanks to your excellent talk. Thanks, Walter, for your presentation. Now we hand over to Basil to present his plans for the MS cohort.
So multiple sclerosis is an important illness, and this is the commonest cause of disability in young adults in Europe and in North America. So Mobilized-D really will be looking to recruiting a large number of MS patients in 4 sites, as you can see, in the UK, Milan, Kiel, and Milligan. And we're really always varied in terms of being able to recruit all the patients that we needed for this study. So MS really, this immune-mediated condition which affects the central nervous system, so that's the brain and the spinal cord, resulting really, as I said, in really significant impact on patients, particularly in terms of their ability to ambulate. It's got different phases. The bulk of patients will have the so-called relapsing remitting initial phase, where a patient will experience relapses depicted by neurological dysfunction, from which we recover either partially or completely. That is normally underpinned by a lot of inflammation in the brain spinal cord, and also, more importantly, axonal transection. And that's important because once you've damaged the axon, really, there's nothing that you can do about it. And then gradually, disabilities start to accumulate on those patients, and they become more disabled. And that is underpinned by a lot of atrophy and demyelination in the central nervous system. And gradually, patients become more disabled. They develop atrophy of the brain spinal cord. And then you can detect that by imaging. You would imagine really the impact of MS on the brain spinal cord will result in a wide range of symptoms. So problem with vision, speech, swallowing, the use of arms and legs, bladder, sexual functions. But really, walking disability is very important and encountered in the majority of patients. In fact, this is very important. If you ask patients as what's really important in them in terms of their bodily functions, they will say really that their ability to walk is very important. Patients think that the vision and cognition is more important than walking, but walking is very important. If you ask clinicians, they will put really the walking as being the most important aspects of the impact of these patients on all their patients. MS is not really a benign illness. This is really looking at patients in terms of their mobility using a scale called EDSS. And you can see really that the bulk of the patients will get worse gradually over the time. They become more disabled in terms of mobility. A group of patients will remain relatively stable with benign illness, not a lot of disability for 10 years. We call that benign MS. But look what happens afterwards. If you follow those patients up year in year, you see more patients becoming more disabled. So really benign MS is a misnomer, and this illness is an extremely aggressive illness which need to be treated. So how do we assess the impact of MS on patients, particularly in terms of clinical trials? Well, clinically, we use this scale called the EDSS, and both really in terms of our ability to assess patient clinically and as an outcome measure in clinical trials, but also we use relapse rates and we use other clinical assessment, but we also rely on the use of imaging as an outcome measure, again, both clinically and in terms of clinical trials. Here's the EDSS. That's an ordinal scale which goes from 0, indicating MS has no impact on patients, going up to 10, indicating patients are dead due to MS. And there are half points. But really, anything between 4 and above really will be determined by how far patients can walk. So a patient with an EDSS of 4 will be able to walk 400 meters. A patient who has an EDSS of say 5.5 can walk 100 meters unaided. Somebody who has got an EDSS of 6 will walk 100 meters with the help of a stick, 6.5, 10 meters with support, and so on and so forth. So ambulation is very important in determining where is a particular patient in terms of disability on that scale. So that scale is very famous. We cannot get rid of it, but it is not really the best of the scales. It's got bimodal distribution, and patients spend variable times on the particular points in that scale, with the beginning and the end of that scale really so being very insensitive. So a patient will spend a long period of time to progress between 6 and 6.5 and 7, but will spend a relatively shorter period of time progressing in the middle part of the scale. We think we think that DMOs are far much better outcome measures compared with the EDSS, and in fact, work has been done in various parts of the world, including here in Sheffield, where we looked into using wearable sensors to try to quantify ambulation. And we found that these wearable sensors are not only very effective in telling us the difference between patients with healthy controls and patients with MS, but also the difference between various types of MS and also various degrees of disability in patients with multiple sclerosis in terms of the rhythm of the gait, the variability, the balance and coordination, and so on and so forth. So this is an extremely promising outcome measure that we can use really to assess our patients with multiple sclerosis. And in fact, this is the work really which we referred to a little bit earlier. Actually looked into the literature to see how many trials in the past or papers have used really DMOs to assess mobility in patients with multiple sclerosis. And you can see that there is a significant work already published, looking particularly in terms of gait speed and cadence, strides, and so on and so forth. But really, what is surprising is how much of that has been used in marketing authorization of drugs as a primary outcome measure. And you can see a reference really sort of to CODP and Parkinson's disease, but you can see in multiple sclerosis, EDSS has been the main outcome measure. with other outcome measures being used as well. And the bulk of the trials really relied very much on MRI scans and relapse rate and so on and so forth, really. So we needed very much, really, the Mobilise-D to move us forward towards using an outcome measure which will help us assess our patients in a more sophisticated and sensitive way. So to summarize then, we think mobility-related disability is an extremely important aspect of this illness and has a major impact on patients. EDSS and other outcome measures have been used really to assess both the accumulation and the progression of disability in MS clinical trials and in clinical practice. But these outcome measures have significant shortfalls. And we noted that the published literature has suggested that the use of DMOs is extremely promising as a group of outcome measures. So what we really wanted very much to do is to collect more data longitudinally using DMOs to assess a large cohort of patients with the hope really that these DMOs can be promoted to be used as outcome measures, secondary and hopefully primary outcome measures in clinical trials. And I'll stop here.
Thank you, Basil. Now it's the pleasure to have the stage for Professor Taraldsen, who will present the thoughts on the planning of the hip fracture cohort. And then after that, we'll have some time for questions and answers from the auditorium. So, Christine, please take over.
Thank you, Clemens. And I'm happy to present the hip fracture cohort today. The clinical sites for hip fracture is located in Montpellier, Stuttgart, and Trondheim, and led by Hubert Blaine, Clemens Becker, and Anna Marcozzi. So, I'll start with this picture because the typical hip fracture patient is a woman. And the mean age is around 83 years, and the hip fracture is described as a life-breaking event, as the situation for many changes from living independent to suddenly being very unsure about the future. Hip fracture patients are geriatric patients where frailty is expected and will affect the recovery after the fracture, as illustrated in the figure from Clegg and Rockwood. So, we know that there are 1.3 million hip fractures worldwide every year, and the numbers are expected to be 6 million by 2050. The costs for the society are high, and the burden for the individual is also high, with 30% mortality at 1 year and a substantial loss of healthy life years with reduced mobility and greater dependency. So, with a hip fracture, there is a sudden loss of function with the fracture. And optimization of care starts immediately. We know that hospital treatment is essential for the recovery and include early surgery. But after the surgery, rehabilitation starts with the aim to get people back on their feet and walk again. And there are no pharmaceutical interventions available, but we have different exercise interventions to improve mobility. And depending on the treatment, different recovery patterns are expected. So, this is an updated Cochrane review from last year, including 28 trials and more than 5,000 patients. And they concluded that with moderate certainty evidence that rehabilitation after hip fracture surgery, when delivered by a multidisciplinary team, and supervised by an appropriate medical specialist results in fewer cases of poor outcome. And one of the trials included in this review was the Trondheim hip fracture trial. And in this trial, comprehensive geriatric care in a dedicated ward was compared with usual treatment during the hospital stay. And this study included almost 400 hip fracture patients. And results showed effects in favor of the comprehensive geriatric care on the primary outcome, mobility at 4 months, measured by the short physical performance battery shown in this figure. The intervention group is shown in red in this figure. And also there were positive effects on secondary outcomes on more specific gait measures and also daily physical activity outcomes. And this study was also cost effective. So in this trial, we offered ideal treatment, and we know that for many hip fracture patients around the world, the more ideal or optimal treatment is not always offered. And we also have a lot of knowledge about different exercise intervention studies. And we know that exercise can improve mobility. And also exercise interventions starting when rehab periods typically ends can further improve mobility. But we also know that characteristics of the patients can limit recovery, where, for example, non-frail hip fracture patients show the largest recovery of mobility after the fracture. But nevertheless, by current practice, patients do not get back to their baseline status. And we do not know if it's due to access and delivery of medical care, surgical care, rehabilitation, or characteristics of the patients and the hip fracture injury. As illustrated in this figure from the Trondheim hip fracture trial showing ADL function, where you clearly see that although the patients achieve recovery, baseline status is not reached. So most patients will have a more restricted life situation after the hip fracture than before. So here is a slide from the same review as the others have also presented. And for the hip fracture cohort, we found digital mobility outcomes only reported in 48 studies. And gait speed was the most reported outcome. Some studies used more gait-specific outcomes from gait analysis, but 85% of all was from in-lab settings and not from real world. There were also few good quality RCTs that reported Dmos, so there is a need for larger, high-quality studies in this population. One other important point, as illustrated here from an exercise trial we conducted 4 months after hip fracture, and that is that gains in gait speed from in-lab settings may not be transferred into gains in real-life measures. And as we found, the exercise offered was superior to usual care in terms of changes in gait speed. But we did not find any transferred value into the measures from real life, here shown as upright time from activity sensors. And there is suggested that only greater improvements in gait speed is perceived as mobility improvements after hip fracture. So to sum up, hip fracture is a major challenge, both to patients and the healthcare systems. Mobility loss is an acute consequence, and we know that few regain their pre-fracture levels of mobility. And the most promising parameters by now is gait speed and upright time. But there is a need for more knowledge, and that's why the Mobilized project is very needed. So thank you.
Yes, thank you, Christine. So far, we're opening up. So currently, please, Mara, correct me, there are no questions in the chat. Maybe there will be some remarks coming up. From my side, I would like to thank, let's say, all the different speakers of today of the webinar. What this project has told me that it's more than relevant, let's say, to work in very multidisciplinary, let's say, projects. I think that the reality is that, of course, what we see in the clinical world are increasing numbers of people that have also multi-morbid conditions. So, for instance, also Professor Trostas has shown that, for instance, many COPD patients, of course, have cardiac problems, have muscle problems. I think it's also very well understood that we need this crosstalk between the different specialities to learn from one another. I think another point that does come up and will come up is the need for comparative effectiveness research. I think as soon as we enter into the discussions with health technology assessment, that also we will need comparisons using also health economic parameters, which is not the current scope of Mobilized, but will be definitely needed in the future. I think we have one question that came in, let's say from Arne Müller. He's asking what are meaningful, clinically meaningful changes in gait. And he's asking specifically towards Parkinson's and the hip fracture cohort. So maybe Walter, you can start, and then Kristin, you can comment on changes in gait speed in hip fracture groups. Walter, please take over.
Thank you. This is also a $1 million question, and we are looking for the answer. And I'm not sure whether this is really already available in the literature. So I used the last seconds to check the PubMed whether there's already something available. And there may be some first attempts for deep brain stimulation that may assess gait speed changes and how this relates to clinically important improvement. So this is my comment now. It may be that others know more about it. I think what we need at the end of the day is maybe also separation between different sub-cohorts, maybe some very different if you talk about early Parkinson's disease or moderate or advanced Parkinson's disease.
Maybe Lynn, you can also step in.
I think given the topic or the focus of Mobilized, one of the key questions is when you ask about what is clinically meaningful. Well, that's very different if you ask someone to walk up and down and measure their gait speed over 4 meters with a stopwatch. But what is clinically meaningful, or what is meaningful to a patient, is their walking speed in the real world. And we don't have those meaningful estimates. And that's precisely what we're trying to do. One would argue that that's where the change needs to be seen. So as Walter's quite rightly said, we need to understand what this is with respect to different levels of disease severity and PD using these standardized tests, but we're trying to be a little bit more ambitious than that. In Mobilized, we are really trying to look at meaningful change in the real world, and that is an area where I dare I say there is no evidence at all.
Maybe it's fair to add, I'll hand over, Kristin, to you in a second, that there's quite a bit of work also on qualitative aspects led by Laura Delgado from Barcelona. We have a very deep interest to look how patients perceive mobility and changes in different aspects of mobility. And then gait speed, of course, would be one of the features, how relevant it is, for instance, like crossing pedestrian walkway, how fast you have to be without being killed if you walk in a very busy environment. But there's no easy answer to that. Kristin, from your side.
Well, I support what has already been said, but from in-lab settings and for gait speed, the typical cutoff is 0.1. But as I said, for hip fracture patients, they are very frail and they walk very slowly. And maybe in that cohort, we don't get the immediate transfer into more activity, for example, because they are frail. And yeah, as Lynn said, we don't know much about daily life measures, and we don't know good cut points, and maybe not the best measures either. So yeah, we need to know more, I think.
Maybe I can add on the hip fracture side, what we have seen in 2 randomized controlled trials on exercise, that the changes in gait speed and hip fracture were relatively modest, something like in the range of 20%, where the increases, for instance, in gait volume have been more than 100%. So I think this is really one of the stories that I learned, is that we have to look at different features. And of course, we also have to listen, let's say, what is meaningful to patients, and not only what is meaningful maybe for us. There's a comment from Beatrix. Maybe Beatrix, you can unmute yourself.
I was thinking maybe one of you would mention this. So one aspect of the CVS is that we ask the patients what is relevant for them. So we have interviews with a subset to find out, okay, one thing is what we can measure clinically and what might be clinically relevant and what we objectively measure. But the other really important aspect is asking the patients what matters to them. And that goes back to what Lynn was addressing in her introduction. So that's part of what we're doing.
Yes, I think this is quite relevant to emphasize. I think we have all learned that we're not digitally obsessed, but let's say, of course, we want to be precise as possible, but we definitely have to listen to the voice of the patients. So once again, I think this is also a nice bridge that for the next webinar, these will be some of the aspects that will be covered. Maybe Lynn, you can briefly re-mention what is planned for the next webinar.
Well, the next webinar will really highlight the work that we've been doing in Mobilise to ensure that we are working collaboratively and in a co-design fashion with all of our patient cohorts that are involved, so that everything we develop is going to be fit for purpose. That means not only is the device usable, but do the measures themselves have meaning to patients? What do they feel about their use of their data, all the ethics around data sharing? What do they think about mobility per se, mobility as an overall topic, and how that changes in the context of the different conditions that they experience? So there's going to be a whole range of topics that we are working collaboratively with our patient cohorts on through the patient and public advisory group and through the patient forum. And what the webinar on the 1st of June will introduce is the approach that we're taking, and you'll hear from some of our patients themselves within that webinar.
Thank you. We have one more comment in the chat. I'll just read it. It's going to be interesting what health authorities think of how we measure meaningfulness in the real world. And the question is Mobilized going to be setting a gold standard for that? I think that, Lynn, that's a question for you.
Thanks, Clemens. Well, we have different ways of measuring meaningfulness. Arne, thanks for your question. We can look at clinical meaningfulness, where we have anchors to register change with respect to real world walking that patients themselves will evaluate. So that is what they perceive as a meaningful change, improvement, or maybe progression. We have other scales that relate to activities of daily living. So the ability to be able to move around and carry out activities of daily living. So we can look at the relationship of our DMOs to those scales. We're also carrying out qualitative work as well to explore the patient experience, their perception of mobility, their lived experience of mobility, and how that can be best reflected, or if it is best reflected, in the measures that we are validating and have validated. Clemens briefly mentioned before the work of Laura Delgado from Judith Garcia's group in Barcelona. So they've produced a really very detailed model of mobility, and this will form a cornerstone as well of our body of evidence that we will demonstrate clinical meaningfulness with. But to be clear, it's not one single outcome. We need to take multiple different perspectives to demonstrate this.
There was a comment from Kerry. Please, Kerry, unmute yourself. On
Well, everything is in the comment. So I was happy to hear from Kirsten that 0.1 meter per second, I guess, then is considered clinically relevant. And if you look at COPD, 30 meters in 6 minutes is there considered to be the minimally important difference, and that's 0.08, so close to 0.1. So it sort of goes in the same direction. So that's for walking speed. I think we could follow the 0.1 there. And then for physical activity, Helene Meyer published in Chest work on what would be clinically important in terms of physical activity volume, and there about 1,000 steps per day was considered to be relevant. In that, patients who improve more than 1,000 steps after a rehabilitation program were less likely to be readmitted to hospital. So that could be a first avenue forward, but clearly we need more information there also to convince regulators, and hopefully Mobilise-D can help us with that.
Maybe as a brief comment, as part of the assessment, we're also looking at life space. So of course, changes in life space will be quite relevant and meaningful. Very often, of course, patients in terms of goal setting will say one goal is to go back to the next pub or to the next grocery or whatever it might be. So I think from an ecological point of view, this will be also quite relevant to look at. But I think briefly wrap up. It's 6 o'clock. I think this has been a first insight into the clinical validation study. After the summer break, we will have 4 separate presentations of the cohort, including, let's say, first results of these. You will be invited to join for those. Good. I'd once again like to thank all of you who have attended, share the news, and we'll keep you posted. Thank you. Bye-bye.